Welcome back to Cancer Buzz, the podcast for cancer care professionals. Today, another installment of our special series on delivering quality cancer care during the COVID-19 pandemic. And we take a look at the impact of the pandemic on surgical oncology. Dr. Lawrence Wagman is a surgical oncologist at City of Hope Medical Center and the regional medical director for the City of Hope Inland Empire region in the Los Angeles area.
There are a number of patients who have anxiety about coming in for visits, and so they're staying home, and even with new diagnoses, those who were already diagnosed and are in the follow-up period, because of the availability of screening, say a woman who's had a breast cancer needs to get another set of mammograms, the mammogram center may be closed, so those were delays. Not as much with CT scans or MRIs, but to a certain degree that, maybe a patient with a colon cancer and a liver metastasis, those kind of impacts. As far as doing operations in the hospital, the biggest impact is bed availability and bed availability in high-risk parts of the hospital. That's changed over time. Early on, it was not knowing when the surge was going to occur. So in Southern California, early on, so that was March and April, there was not that much COVID positivity. We had small numbers, maybe numbers in the 30s of patients in hospital and maybe half a dozen patients needing ICU. As the surge has come on, now there are 90 patients in the hospital and maybe less in the ICUs, but still a significant number. So that was bed availability. And that factored into whether I thought it was safe to bring a patient for a major operation where they might be in the hospital for an extended period of time or might need to use the ICU for an extended period.
Dr. Wagman, did the pandemic bring any impacts to surgery that surprised you?
There was a very positive aspect to it, particularly for breast cancer, and particularly for breast cancer where you needed assistance from a plastic surgeon. So for the women who could come in, have their breast surgery and go home the same day, that was excellent because the operating suites and the bringing the patients in and out was very, very highly regulated and managed. And for the women who needed breast reconstructions and might just stay overnight, now there were much more availability on the calendars for the plastic surgeons who, on a normal work profile, be doing much more cosmetic surgery or office-based, and that had totally stopped. So I could schedule a breast reconstruction patient pretty much whenever I wanted because the plastic surgeons were now available.
Now, because of those bed availability issues, do you need to prioritize patients?
So at the beginning, when this all came out, we were told that every patient needed to be reviewed by our president of the medical staff, chief of surgery, and chief of anesthesia. And we came to an agreement very quickly that we would book a case and put it in for scheduling, and within 8 hours, we'd have a call back if there was any question. And so early on, it wasn't a problem at all for us in terms of beds. Now that more beds are being taken up because we have the California surge, I haven't had anybody declined, but I know that I'm being very careful about who I ask to bring in.
So how does your staff determine which cases take precedence?
Anybody who has a known diagnosis, who's at a point where they need their surgery, and there are no alternatives for therapy, they become number one. I had a patient who we weren't quite sure of the diagnosis, so I prioritized that person to wait because I felt that in the absence of a diagnosis, we'd be better off rescanning them. Otherwise, pretty much anybody who's eligible is brought in, and every patient has to have COVID testing before they're allowed to be operated on. I've only had one person completely asymptomatic who got delayed, and that patient was operated on a month later.
How are you dealing with patient backlogs?
So some of the practices also carry a general surgery practice. So the surgical oncology, the surgeon will do 80% surgical oncology and 20% benign. So maybe hernias or gallbladders or lumps and bumps. That part of it went into a backlog. And as soon as things opened up, those patients came back in. But even for colorectal, where we know the patients would be in 2 or 3 days, With a rectal cancer, you usually get chemotherapy and radiation up front. Sometimes it's total treatment. And then there's a timed operation to follow that, maybe 6 weeks. Since there was no problem with delaying those patients, because you can probably wait any number of months before you operate on them, everything was just put on a list. And as soon as things became available, the patients were brought in quickly to take care of them. If somebody had a colon cancer, then that got taken care of pretty immediately because that wasn't considered elective. It's not emergent, but it's not elective. So I would say the only part for the surgical oncologist was the non-surgical oncology cases.
Have you been able to inch back toward pre-pandemic operations? Or are you still operating in a modified way?
In the community, we have a little more of a selected patient population that the operation itself is of lower risk. So a gastrectomy, I would delay until I was sure the patient could be overnight in an ICU. But a patient who I thought might need a week in the ICU after a liver resection and potential liver failure post-op, I wouldn't do that now. We'd have to wait and maybe find an alternative therapy in the interim. Now, the other part of it is that we learned a lot because the rules were given to us at a time of hospital-based and healthcare anxiety, meaning that everybody was so nervous what might happen. You know, our governor didn't want anybody over the age of 65 working. Our governor had a lot of things that were really very anxiety-provoking early on. So we said, okay, let's take that set of potential problems. How can we design things to get through it? Which is what we did, and it worked so well. So now when it's actually happening, we've already kind of thought it through. And I think the individuals who are the surgical oncologists have already educated themselves to safety models and are acting that way, which I say we're kind of used to it.
Check out the show notes for more on surgical oncology during the pandemic. Next week on Cancer Buzz, we will dissect pandemic data and learn how cancer programs can better understand and incorporate COVID-19 data into their practice. Until then, for the Cancer Buzz team, I'm Summer Johnson. Stay well.